Thanks, Katya. This is Jerry Zion. What we're going to cover today is the clinical role of defibrillators, that is, their intended use, reasons for thorough defibrillator testing, because there are some wonderful innovations that have been built in to today's modern defibrillators that a regular plain old defibrillator analyzer cannot test. And so we're going to talk a little bit about that. And then multiple questions about multiple loads. So cardiac life support devices, that includes defibrillators, not only AEDs, but full up ACLS, advanced cardiac life support defibrillators, and the pacemakers that are and have been for a long time built in to today's ACLS defibrillators. Those are what we mean by cardiac life support. And the pacemaker, for example, is a steady hand guiding your heart through each day, meaning it's there if your heart is speeding too slow. The pacemaker, even a temporary external pacemaker, is there to help your heart beat at a rate that is appropriate, more appropriate for a better quality of life. And while the defibrillator, on the other hand, is your guardian angel, standing ready to keep you safe if your heartbeat becomes dangerous regular, including life-threatening arrhythmias like VFib, which is what you normally will see it used for. But the other thing that we're talking about there is the synchronized cardioversion if your heart rate is too fast. So while the pacemaker is helping your heart if it's too slow, the defibrillator can be helping your heart if it's too fast or if there's a life-threatening arrhythmia. So here's the critical jobs that convert certain heart arrhythmias to normal or more normal. They convert VFib back to more normal, not necessarily normal, and monitor all patient parameters to ensure effective treatment, beat by beat, breath by breath. And Justin, you had a comment about this because these devices are not just defibrillators anymore. They incorporate more, right? You want to say something about that?
Yeah, I sure did. When I started working on defibrillators 20 some years ago, it was literally just that. I also am a firefighter, and we would normally just carry a defibrillator in one hand. And then if you wanted a patient monitor, it was a separate box. And then as time has evolved and defibrillators have evolved, we married those two devices into one box. And we had monitor defibrillators. And then as time went on, we went ahead and added pacer to it. So now we have monitor, defibrillator, pacers. So you're actually testing three devices when you're looking at that defibrillator that's on the shelf. And depending on where you're at in the hospital or where you're at in the medical field, it could have many different names. When I'm with my ambulance crews or with the firefighters, they call them monitors. If you're on the ICU, it might be called a defibrillator. So that box can have multiple names, but it actually has a lot of parameters and a lot of jobs inside of it. So there's three different areas that need to be looked at.
And yes, and as time has gone by, more and more vital sign parameters for the monitor part have been added. So now we have up to 2 invasive blood pressures, sometimes
Or more.
no more.
Yep, up to 4 of them some now. Some of the
Right.
Zolls have up to 4 lines now. Yep.
Yep. NIBP for cuff blood pressure. In addition to that, pulse oximetry and pulsed co-oximetry, which is the Masimo Rainbow brand of that capability. Those are all new functionalities within the last, 15 to 20 years.
And tidal CO2.
Mm-hmm. Yes,
Yep.
and correct, yeah, and tidal CO2 as a more direct assessment of what's going on with gas exchange, which is the whole purpose of ventilation, which is a whole nother webinar that you're going to want to listen to, right? But all of these things are now incorporated at least into the full ACLS defibrillators, and sometimes even those bigger defibrillators, more complete ones, those go on the ambulance as well. Those go in the aircraft as well. So it's not just what's going on in the hospital, it's also what's going on everywhere where we know we need to be able to defibrillate the patient.
Or monitor them.
Yeah. So AEDs, just to kick this one off, AEDs are wonderful. They are advanced, are automatic external defibrillators. They are designed for a first responder who really doesn't know anything about physiology of a patient to be able to successfully deliver a life-saving shock so that the chances of the patient surviving a cardiac arrest, a heart attack, are higher. And the AEDs are very special little devices because they have to know how to interpret the, the ECG and the arrhythmia, because the first responder that's going to use them doesn't know how to. And so these things have a lot of sophistication built into them. But like, you know, like Scotty said on one of the recent Star Trek movies with the Excelsior spacecraft, he said the more fancy they get, the easier it is to bollocks them up. And certainly that's happened to AEDs. We've had microchip failures, battery failures, power supply and recharging circuit failures, inadequate energy delivery, usually related to the ones that I've just gone through, or non-compatible pad connections. And Justin, you had some experience with this too. You want to share?
I sure do. So with this, when you're starting to take a patient, and you bring in a patient from the field, so you might be in the mall or your home or camping or wherever that person or potential victim has this heart or cardiac event, you're going to immediately start treating that patient there. The quicker you can get that AED on the patient, the better chance you have of reviving the patient. So we were just last night, I was just last night taking a CPR recertification, and this is a topic we talked about, you know, continuity of these pads. So if you're treating a patient in your mall, your home with whatever AED you have there, and then the medic's going to get on scene and they might have to change out the pads. So when they're changing the pads on the patient's chest, you have to stop CPR. You have to stop defibrillating and monitoring the patient so that those pads can be changed. You know, if you're operating like a pit crew and doing it really quick, it could be 30 seconds, but that's 30 seconds that you're not beating or that patient's heart. So that takes time. Well, then you package the patient up. So you're going to wrap the patient up. You're going to get them on a backboard. You're going to get them secured down and into the ambulance. And then if it's determined that you have to fly that patient, you're going to get the helicopter there, the stat medevac, and they're going to open up the doors, bring out their monitor defibrillator. Is it compatible with the pads that you have on the patient? So they might have to stop everything, unpackage the patient, and do it again. Fly them to your hospital. Now, is your hospital compatible with what's on the bird? And again, you might have to stop what you're doing and change those pads. So there's a lot of money that can be thrown down the tube there because you've had to change out the pads 2, 3, 4 times, you know, in the worst case scenario. But more so than the money is the fact that you've had to stop patient care 3 to 4 times to change those pads. So when you're considering your defibrillators or looking at the flow of them, look and see where you're starting at from your local area municipalities up through to your ICU, and make sure that you have those pads are compatible the whole way through so you don't have to stop that patient care. And then when you have those pads, you know, you have to change those out every so often. They will dry up. They have an expiration date on them. So one of the largest failures is making sure that those pads are still in date and not opened. You know, some people want to be there and get them on as quick as you can. So they've had the pads open for a few days in preparation, but every time that happens, they're drying out. So the education of that to your responders and your medics is also something that can be passed down the line.
Right. Now, typically, these are part of the supplies evaluation that that the clinical unit or the response team is responsible for. There's a couple of different intervals for that include looking at the dates on the pads, but certainly once a month is not unusual. But the biomed when you go to do defibrillator testing, it's also your responsibility to take a look at those pads that are available on the top of the code card or wherever it is. Make sure there's eyes on those dates,
And
because
on
as
the battery.
Justin said, yeah, and the battery as well. As Justin said, if somebody misses that and the pads are dry, they're not going to work. And now we got a patient that can't be treated, or a
Or
patient
you
where
might
we've
have
got too many
higher impedance
switchovers.
across
Yeah.
their chest.
Yes, right. Exactly. Exactly. So let's move on. There's global standards and regulations that set forth requirements for what has to be tested and a little bit about how it's tested. The US FDA and ministries of health leverage the international or local national standards. So these would be IEC standards. Any ANSI standards also apply for defibrillators here in the United States. Manufacturer specifications are also part of the setting up the requirements, and they also leverage the international or local national standards. Much more likely the international standards, because most of the manufacturers, for sure in the United States, also sell their products elsewhere. And companies that make defibrillators that are outside the United States have to comply and get clearances to market their product before they can bring them into the United States market, and the US FDA has control over that. Furthermore, during accreditation audits by of healthcare facilities by Joint Commission, DNV, HFAP, these are just three that we know of, accreditation organizations that will come in and have a look at how well how safe your environment of care is for that patient, treatments and things like that, and how well we as biomeds are managing those medical devices and making sure that we're performing our quality assurance testing and measurements and making sure that these devices remain safe and effective for clinical use. Now, here's a question for you. Do you know what your body's transthoracic impedance is right now, right at this moment? Let's give you, a minute or two to answer that question in the Q&A, please, and then we'll divulge what a good response might be to this. So please go ahead and make your entries in the Q&A.
We see a few responses that started to come in. Maybe Jerry, would you like to give our audience a few options there, the multiple choice?
Sure, let's give you a few options.
So yes, I do know what my body's transthoracic impedance is at the moment. No, I do not know. And some people may be wondering, what is transthoracic impedance? And so I see a few answers coming in. A few no's. Some of you guys actually know what it is. The 50, 60 ohm, 30 ohm.
Good,
100
we'll talk
ohm.
about that. We'll talk.
No, I did not. Well, Kevin is saying it varies, but the nominal testing load is 50 ohm. That's an interesting answer, and that's exactly what we'll be covering today.
Mm-hmm.
No. Yeah, most of the answers are no, or option B.
Okay, good. Well, let's move on and let's see more information. So here's the real deal. Transthoracic impedance is the body's resistance to current flow. And we are going to deliver our defibrillation shock through the skin, which is why we have the pads, and we try and reduce the resistance, the skin resistance. But that's not all of the resistance that's presented, because that current that we're delivering has to get all the way to the heart itself and depolarize all of the heart cells in order to get the heart to come back to a more normal rhythm. So it turns out that the clinical studies and the US and the international standards see human impedance variability as typically it can vary between 25 ohms to 180 ohms in the clinical studies results. And by the way, it's even it's different between you and me, or or you and Katya, or you and Justin. That's right, to understand that it varies from person to person, but it also varies within the same person from time to time, from a time during the day to another time during the day, because it's things like your skin resistance. It's things like how much muscle mass versus how much fat mass is in your body and your body conformation at the, at the time. That may not change moment to moment, but it will change over time across months. So there are a lot of things. Are you older or are you younger? Oh, things like that that cause it to be able to vary more than you think. So
Hydration levels.
yeah, right, Justin.
Hydration levels are a big one of them. Do you use moisturizers? Are you hairy? I'm a 245-pound hairy woolly mammoth, so a lot depends if I shave my chest today or not.
Mm-hmm. Mm-hmm.
And
So
how
that's
much can they rip
part.
off with those pads?
So just to reiterate that the energy, the current flow has to be generated in the heart. So it's got to get through all of this different tissue impedance, and each tissue type has a different impedance as well. And so it's got to transit through all of these different kinds of tissue, fat, muscle, and so forth, in order to get to the heart in the first place. So these are some of the things that we talked about. So the idea here is defibrillation is dependent on a combination of current and duration. Current for how long? This is the strength duration relationship, and there's a range of shock durations, and some require more and some require less in terms of the amount of current. And we translate that into the defibrillator settings that are actually measured in joules, which is a unit of work, is what it is. A joule is a unit of work. And that's because we cannot directly measure the current flow all the way to the heart tissue. So we measure it in joules. How much work in terms of this current are we pushing into the patient's physiology? So we'll move on from this to give you a little bit different view. It kind of looks a little bit like this. So the blue box is the defibrillator, and these resistance or impedance values out here are the patient. And this is the math formula that we would use. So the energy in watt seconds or joules is the square of the current times the resistance times the time. And so those of you that are really much more, helps you to see more of the schematic way of looking at this. That's why we included this slide for you. So there's also still some monophasic. So these are Edmark-Lowen waveforms. Monophasic means they only go in the positive direction for a specific duration of time. And they were great, but we needed 360, sometimes 400 joule settings on the defibrillator in order to ensure that we delivered a successful shock therapy to a patient who had fibrillation.
And if I remember right, Jerry, it pretty much only caused the heart to contract. There's nothing to force it to release. A monophasic waveform pretty much just made your heart contract once.
I could, but the big thing here is to get all of the heart cells to depolarize at the same time and be ready for the next pacing signal from the heart's own pacer, from the the nodes that are the pacer nodes in the heart to get the heart to come back to a more normal rhythm. Biphasic energy goes both directions. It goes positive and it swings negative for different times. And those times in the two phases, the positive phase and the negative phase, are important to understand also. And sometimes we might, I don't know whether we'd set testing limits on those because there's no pass fail, but in terms of understanding across not only the 50 ohm standard load that's built into our defibrillator analyzers, but any other load that we're able to present to the defibrillator at a particular energy level to make sure that we see the appropriate amount of time in order to get the current into the heart. All right, so that's kind of what we're looking at. Let's take a look at some of the different waveforms. If we use an oscilloscope on the output, the oscilloscope output of our defibrillator analyzer, we can see these. And so we'll give you a little view from some different manufacturers that we know of. So Zoll has this rectilinear biphasic waveform. So it looks, that's the way it should look if everything is working well on a Zoll defibrillator. A Philips defibrillator has this kind of trapezoid looking delivery. And you can see the timing for phase one is this distance in between right here. The timing on phase two is this distance right here. Okay, and so you can see we've got a little bit more negative going than we would have in the Zoll, at least in this illustration of the Zoll energy pattern. We're not going to judge here which is better or worse. That's a clinical. When your medical device selection committee is looking at replacement or new defibrillators, then there's one down here that is not US FDA approved or cleared for the US market. And this one is from a company called Schiller, who sells their defibrillators around the world. And this is a pulsed biphasic waveform. So you can see the little pulses and you can see the duration appearing a little bit longer on phase one and also on phase two, but it's because we're giving shorter pulsations of energy and current delivery. And the result here is the energy setting that's needed for successful defibrillation can be lower. And that means less potential tissue damage in order to get the job done. And so that was the whole reason why we did all of the study and the research and the innovative work to design biphasic energy delivery. And you can see it's being adopted across most of the modern defibrillator manufacturers today. So if you're not looking at the waveform output, you know, when you're doing your measurements, you might want to think about starting, or at least do that when you're doing your repair on any energy charge up and any of the energy delivery circuits in that defibrillator as part of the post-repair assessment. Make sure, well, you might look at it on incoming inspection too, because you need to know how it looked when that defibrillator was brand new and everything was working right. And then you need to know, did you return it to that capability after the repair? How good is your repair? You need to look at that. So the problem here is too much or too little current delivered to the heart is not good. Too much peak current can cause injury to the heart tissue and other tissue. Too little means we didn't defibrillate the patient. So we'll take a look at why testing with more than just a 50 ohm load is necessary in order to understand the functionality of the defibrillator. So we'll take a little bit review here again about the various impedance values. Each hospital's equipment history should be considered relative to other test loads. Standard protocol recommends multiple impedance testing, incoming inspection, and after repair, as I just said, those 2 times for sure. And then it might be helpful when you're troubleshooting, like when the clinical unit doctor or the nurse tells you to come get the defibrillator because they think there's something wrong. They don't believe it delivered the appropriate amount of energy. You got to understand, how am I going to prove whether it did or whether it didn't? Because sometimes it's going to be the defibrillator malfunction and other times it's something else. And you need to have some basis to go back up and have the conversation with the doctor or the nurse who questioned it about when the defibrillator is working, how you know, and that it must have been something else. We're not going to say what else. No blame here. It's not our job. We're not doctors or nurses, but we can say that. So the loads recommended are the same ones that are recommended in the standard. So the IEC standard for this is IEC 60601-2-4. And then the local national standard has been AMI ANSI DF 80. And they both actually say the same thing because they've been harmonized these days. But we know that you guys, by and large, don't read the international or local national standards. You just follow the test procedure and you do what you're told. You really ought to dig a little deeper. You can know more if you want to know more, but this is where the requirements come from and what the test loads are at which the standard wants every selectable energy level to be tested across. So
Hey, Jerry.
every yeah, go ahead, Justin.
And I'd like to add that some of the new service manuals are starting to put this in it. So if you get to the end of the discharge section, you might see a table at the very bottom of it or possibly at the top of the next page where you'll start to see these resistance loads where they'd also like you to discharge at. So not only has it been in the standards, but now it's starting to finally come out and be in the service manuals. So you might want to review your service manuals too.
Yes, do that. The way that the ones that we have seen so far, because we can't look at every single one either, every single service manual test procedure, but the ones that we've seen typically will want the maximum energy level to be tested across more than one load, whether it's all of these or just some of these. 50 ohms is always included in there, but they may want some other loads as well. So you probably will see now the maximum energy setting. And now that could be 360 joules, could be 200 to 250 joules, or it might start at some point, like with an AED. An AED may start with a lower energy setting, and if that fails to convert the patient, it'll increase the value, and the next shock will be at a higher energy setting. So there will maybe 2 to 3 different energy levels that are delivered through a defibrillation cycle with an AED. And if you don't know how your AEDs are functioning relative to that, it's not enough to be able to just leave it up to the software inside that AED to judge whether it's working or not, because 84,000 or so incidents of AED and defibrillator failure are telling us that whatever we're doing now, if all we're doing is trusting the AED manufacturer's software to tell us that AED is functioning right, that's not enough, because we still have these incidents of killing patients or harming patients, failing to deliver adequate therapy to patients. So there's a very good reason to at least do incoming inspection, post-repair, and then troubleshooting clinical unit complaints with more than one load. So what are our available solutions? Well, full disclosure, we're not the only ones that offer a selectable load accessory for your defibrillator analyzer. But if you don't have one, you're not able to test this functionality that is in the modern defibrillator, and it needs to be tested. And you're going to begin to see it, as Justin is saying, in the service manual test procedure is going to require it. So how are you going to do that if all you've got is a defib analyzer that has a 50 ohm load? You're not. You're just not going to be able to do it. So it's time to either get the next generation of defib analyzer and make sure you have a selectable load accessory, or to add it to a defib analyzer that is able to be compatible with an external load. So again, I think it's really, really important. Think about this. Think about how you want that defibrillator and or AED to function if you or somebody you love is the next patient who it will be used upon. Standards and all of that aside, I think if you answer that question honestly, you'll understand where we're coming from, right? This is about doing the right thing in the right way at the right frequency of inspection and making sure we're really looking and doing a thorough job of the defibrillator performance and safety assessment. Anything to add about that, Justin?
No, yes, one thing, if you're using this, the 7010 load box with the Fluke Biomedical Impulse 7000, you got to make sure that you have both settings changed, not only the rotary dial on the 7010, but also select the appropriate load on your Impulse 7000.
Yes, and there's other training on that, and the operator's manual is very clear about how to make that happen. So we won't belabor it here in this session, but Justin is exactly right.
You know, when we were in CPR class last night, it made me stop and think. I got 4 children here. My youngest child is 18 months, and we're doing pediatric CPR. And as we're going through the class and covering AEDs and such, the discussions revolving around the differences between child and infant CPR versus adult CPR. Will your AED respond, or will the defibrillator respond appropriately when you have that infant with such low resistance? You know, on the infant, you're running the pads from the front of their chest to the back and to the middle of their back. The resistance is much lower. So are you getting the appropriate energy discharge? I always like to tell the story that my wife had 20 years. She's worked in the hospital for 20 years. And I never watched her lose her mind until our child had to be put into the NICU. Simple thing, he just didn't want to, you know, his oxygen saturations are low. But in that environment, it's so stressful for the parents. So when I always think about these devices having to be used in there, I want to make sure it's going to work appropriately from everything from that itty bitty baby the whole way up through the largest driest skin patients that we have. And that's asking a lot of a device. So just a reason to think about why these loads are so important is 50 joules, actually 50 joules at 25 ohms, as well as it is at 200 ohms or 175 ohms.
Yeah, absolutely. All right, that concludes the presentation part that we had. We hope we've imparted some information that's really useful to you, made you think just a little bit. And now it's time for you to ask your questions.
All right, let me go through the Q&A and see what questions we received. Okay, so the first question that we got today was, how can we check enclosure leakage, touch current, and defibrillator? Is it possible to check AED?
It's a little tougher with an AED because an AED, first of all, is battery powered, number one. So there's no power cord, no ground pin, no protective earth. Now we're talking about electrical safety now, so it's a little bit outside the scope of this webinar, but I'm going to answer it anyway. So the enclosure is not metal, and there is typically no metal test point that is non-earth. So the way the standard describes this test is your test point is a non-grounded conductive test point on the surface of a medical device, defibrillator in this case, that the patient may be able to touch, or that the caregiver, the clinician, may be able to touch while also touching the patient. That's the definition. Well, if it's completely enclosed in plastic, you don't have any conductive test point. And you would think that, well, then I don't need to do the test, but you'd be wrong. That was the one test that absolutely must be done and cannot be avoided for electrical safety. And so you use a 10-inch square of aluminum foil, you tape it down to the touchable surface of the medical device, the defib in this case, AED, whatever it is, and you hook your test lead to the aluminum foil. Now think about why this works. Inside the defibrillator, we have electronics, right, that carry current. So that there are conductors inside, correct? Then we have the plastic. The plastic is an insulator, right? Not a conductor. And then what we're doing is we're creating the other conductive surface on the other side. So we have conductor, insulator, conductor. That describes a capacitor, does it not? And so it is a capacitive coupled current flow, but we need to know how much is there and how it changes given a couple of different single faults. So you're going to use aluminum foil, and yes, it can be done, and no, you can't avoid it. Next question.
That's a good answer, Jerry, because this is the one thing after 20 years in the field, as soon as I joined the Fluke team, that I learned the hard way. Caught me off guard on it too.
All right. The next question, well, it's more of a comment, but I thought maybe we could cover it too. Some manufacturers do not recommend testing the outputs of AEDs for annual maintenance. What do we have to say about that?
Well, here's what we have to say. 84,000 incidents. Hello? What the heck? No, we have to test. Now, here's the problem. Some AEDs have a battery that is replaced along with the pads. And so your testing will need to have an extra pair of pads and that extra battery, and that battery is not rechargeable. So that means when you've done your testing, the pads and the battery get thrown away just like they would if this AED was used to defibrillate a patient. Same deal, the pads and the battery both get thrown away. Other AEDs have a battery separate from the pad, but you're going to need your own battery because it's not okay to use the clinical battery, because that clinical battery has a limited number of discharges that it can provide power enough for. And so what you're going to want is to have a spare battery for however many brands and models of AED that you're going to have that you're going to need to test. So it's a little bit bigger problem if you're a field service engineer that has a lot of client sites and they each have different brands and models of AED. You're going to have an assortment of those things.
The good news on that.
Yeah, go ahead, Justin. Go ahead.
One of the things that we used to do when I was in the field is that the pads and the batteries have to be changed out. We said they all have expiration dates on them, right? Mm-hmm. So we would take the pads and the batteries that are just about to expire. You know, we'd always try to change them out before they expire. So if they're going to expire in August, we wanted to change them out in July. So you'd have a pad and battery there. And typically, you know, you're doing enough of these after a while that you can collect a few of those pads and batteries. And that's what we would use. So we weren't wasting money of going and buying a brand new battery and brand new pad. You're getting ready to swap them out. That's a great time to use them up. Yep.
So output energy testing, absolutely. Shock, the shock advisory or what arrhythmias are allowed to be shocked or not allowed to be shocked, that needs to be a function that needs to be evaluated. So you need ECG simulation with the arrhythmias that are in concern.
Does it have the right protocol in it? Is it using today's version of the American Heart Association or Red Cross? Which protocol is programmed into it, and is it the modern one? That might need to be updated.
That goes to the firmware of the AED. So the firmware, is the firmware up to date? That's another thing you look at when you're testing AEDs. Well, These days, you're going to look at that even if it's an ACLS defibrillator, because why? Because the ACLS defibrillators also have at least shock advisory or an AED-like function. They're not just, you know, what the doctor's going to do manually with them. Yeah. So yes, you really should be doing the testing. And if you have a supervisor that wants to question that, I'll be happy to have a conversation with them. I'm not the boss. All I'm saying is I'm going to do just like I'm doing with you and tease up some thought processes, some thinking about what is it that we are asked to do as biomedical engineers and technicians about medical devices to keep them safe and effective for clinical use. What is that? And that should guide everything that we do and not just trust the manufacturer. That's like having the fox guard in a hen house. Why would you do that if you love your chickens, right? You wouldn't. So same deal. Independent, objective evidence is what we're looking for. Okay. Next question, please.
Okay, so I think we've covered this already in this presentation, but for all of you guys who may have missed this, are there different resistant loads available in the Fluke analyzer as per IEC standards, tests and loads, like other possible to check?
Impulse 6000 alone. The Impulse 7000 is the only model that's compatible with the external load accessory. So both the 6000 and 7000 have the standard 50 ohm load built in, but when you're going to do the further impedance sensing circuit, impedance sensing functionality and automatic adjustment functionality assessment of the defibrillator, then you need this 7010 external load accessory. Or if you're not using a Fluke Biomedical defibrillator analyzer, you need the external load accessory from the manufacturer of your defibrillator analyzer.
Yeah, sort of a similar, well, not similar, but also about a product. Is this accessory, the 7010 load box, compatible with the DNI 4000 product?
No.
Mm-hmm.
It is not. And the DNI 4000, by the way, is obsolete and out of its service life. So you're using something that can't be repaired. I'd be trading that in.
Any model or solution specifically to test AED defibrillator?
Any.
Any.
Yeah, any.
Yep.
Okay. All right. Which test would you recommend to do to AED and with which frequency and time?
I'm sorry, say it again.
Which tests would you recommend to do to AED and with what frequency?
Okay. So first of all, there should be a section in the service manual of that AED, by the way. No matter what the manufacturer says, there should be a section that describes this. But basically, here's what I do when I look at an AED or a shock advisory defibrillator of any kind. I want to see, number one, will it shock a non-shockable rhythm? Yes or no? And so what I want to do is I want to give it a non-shockable rhythm, like normal sinus rhythm should not be shocked by an AED. It's as simple as that. And the AED assessment, or it's going to analyze the rhythm, and it should say to the person using that AED, no shock advised, or no, we can't shock that one. It has, you're going to hear that not only does it tell you shouldn't shock that rhythm, but it won't let you shock that rhythm. And then I want to give it a shockable rhythm, usually just VFib is fine. And then what it'll do, VFib will then cause the AED to properly analyze and identify that this rhythm is shockable, and it should allow the shock to happen. Now, once I've assessed those things, the next thing I want to do is I want to run my output energy tests. All right. However many of those the manufacturer prescribes, or depending on the population of patients served by my hospital or my client medical facility, I want to test several different energy levels that might be used based on the kind of patients, the size, body mass, and things of patients they're going to be treating, right? And then, of course, not every time I test in any case, but certainly on incoming inspection, whether that defibrillator is brand new or if I had to send it out for repair and it came back, that's another instance of incoming inspection. I want to run it through its whole paces. I want to see at least the maximum output energy across more than one of those test loads that we talked about. Okay. And after ready repair, if I've done the repair in-house. Okay.
And then again, Jerry, if you don't mind, again, as long as it makes sure you have the right protocol in it. Is it doing the right sequence that your hospital or facility has adopted?
Correct. Correct. Those are the tests that I do on an AED to make sure that it's working right.
We had a few more questions about, the tests that you need to perform on the AEDs. There was a comment from Stanley here. He's saying most AEDs have an internal self-test, especially in airports, malls, etc. Is that enough to test the unit?
The 84,000 incidents of defibrillator failure, a lot of which are AEDs, are saying, sorry, I don't care what the manufacturer says or what their firmware does, it's not enough. So I'm sorry, no, it's not enough. You can't just look on the little red light or whatever color it is and say, oh yeah, that one's okay. No, the question again, I'll ask it again. How do you want that AED to function if you or somebody you love is the next patient it's going to be used on? Simple. You're going to trust the manufacturer? You have no independent objective evidence that that defibrillator is going to work right. And a preponderance, too many incidents of failure to just trust and move on. I wouldn't. I'll just say, put it that way. I'm going to give you what Jerry would do. Jerry would say, I'm not going to trust them. I'm going to do periodic testing in a more thorough fashion, even if I have to buy extra batteries and pads in order to get that job done, because I want to be sure that every patient who needs that life-saving therapy gets it appropriately.
Jerry, that's something I'd like to touch on as well. Mm-hmm. How many of us carry a flashlight in your car? You probably have a flashlight stuffed in your glove box or in the door panel, right? Or you have a jump pack to start your car. How often when you need that device does it work? I don't know how many times I've been out on the side of the road. I'll pick up my poor wife again here, driving her vehicle, and I grab her flashlight and it's dead because it sat in the door for how many years and we haven't checked it, or it got moist in a rainstorm. All these environments that these AEDs can be in. They could be hauling around in the back of a cop car, bouncing down the road, in the center console of a fire truck. Is it in a personal vehicle? Is it in a section of the mall where it's been forgotten, overlooked? Is it in a high humidity environment? We're in Pennsylvania. That's where I'm at right now. It's been about 93% humidity for the last month. Or if you're down in some of these southern states where it's super hot and humid. All those have effects on the electronics on the inside. You're asking an awful lot of that internal microchip to trust that it's going to be able to catch all those nuances that you would probably catch by actually running it through its paces. There's a lot of environmental conditions, and the more we worked on them, the more we found out that we needed to test them more often because of those environmental conditions. You don't know, something can happen to it. And when you're using your defibrillators and AEDs, are you using them in a nice, calm, cool, collected manner where you have time to troubleshoot something? No, you're panicking. Think about the worst case scenario, and that's when it's going to be used. It's going to be used in a rainstorm. It's going to be used when there's somebody dying in front of you and you're panicked. You have too many other things going on to try to remember to troubleshoot through those things. So he's 100% right. The first time, every time. From so many years in the field, I can tell you we have found these defibrillators have had issues happen because they've been dropped, they've fallen, they're picked back up and stuck in, and not gone the whole way through. So I really do encourage you to stop and look at them. Look at the ones in your churches, in the malls. I mean, you may be surprised at what you find.
Yep. Next question.
This question is also sort of related to what we were just talking about, so I kind of want to cover it all at the same time. Does testing, so additional dischargers, affect the lifetime of the AED capacitors? And if so, how can we estimate its degradation?
No, it's not going to degrade the capacitors. What it's going to do is use up the battery. That's the durable accessory and the power supply of the defib of the AED. That's why you've got to have a spare one way or another that you use to test it with, and don't test it with the clinical battery.
I can't think of any AEDs that are one-time use and throwaways. I mean, everyone that I can think of, you replace the batteries, you replace the pads, and you're right back up and running. I've never seen one that had a limitation on how many times it can be used.
Yeah, no, it's just how many maximum discharges will that battery be able to supply, and that's why the batteries have a limited life in an AED. It's different in a full ACLS defib because they're sitting on a charging stand if they're going to be used in kind of in a grab and go situation, and those batteries are able to be recharged, but that's typically not so much the case with the AED. Batteries might be able to be recharged, but typically not. So yeah, so you got to have the spare batteries, but it's not going to affect the capacitors inside. The
Even the
capacitors
defibrillators that sit on the.
they're
Sorry,
very
John.
long life. Yeah.
Even your AED, even your defibrillators that sit on the cart and plugged in all day long, those batteries can go bad.
Mm-hmm.
You should never let a battery sit in the charger 24/7 without exercising it. Have you exercise that battery and make sure that it will hold a charge when you need it.
Our advice on batteries that can be recharged is every 2 years, you should be replacing those batteries, just for the reasons that Justin is pointing out, about every 2 years. And that's pretty consistently agreed to across the industry, across test instrument manufacturers, medical device manufacturers. About every 2 years, you ought to be replacing even ACLS defibrillator batteries anyway.
Mm-hmm.
Next question.
Yeah, thank you for touching on that, on the whole battery subject, because we got so many questions on that as well. So I hope that answers your question, guys. And let's move on to the next one. The next one is, please highlight if the defibrillator should have, if a defibrillator should have more than 200 joules, what is the use of 270 joules or the 360 joules, and what is the specific application for them?
So those are clinical questions. They are the decision of the, so let me start. Let's start where we left off, AEDs. AEDs either have just one energy setting, or they may have two, some may have three different energy settings. They will typically, their firmware typically will start with the lowest energy setting of the two or three, and then increase if the first discharge does not convert the patient back to a more normal rhythm. So that's the way that those work, and they're built in, and what you got to do is not allow them to have a converted waveform. You got to keep giving them the arrhythmia so that you can see that functionality increase the energy setting once or twice or three times during your testing to make sure it's going to work. In the other full ACLS type defibrillators, the energy setting is dialed in by the doctor. The doctor is prescribing a therapy, and so it's not just any old setting. It's set values that are designed into the particular brand and model of defibrillator in an ACLS defibrillator that the doctor dials or causes a nurse to dial in and then delivers the energy. So no, there's no prescriptive energy level. If you follow the standards exactly as to what they say, they are going to actually have you test the output energy at each and every possible setting. but then they're going to have you do 10 discharges on battery at the maximum energy delivery setting, the 10th one of which you're going to measure a charge time. It's called the charge time test. It's described more in a different training that we have. But it's a test to evaluate not only the battery, but the capacitors, the other parts of the charging circuits and so forth, to make sure that after that 10th battery discharge at maximum energy setting, it's still going to deliver the full amount of energy that it's supposed to.
Thank you, Jerry. I think I need to chime in here really quickly to let everyone know that unfortunately we're at time. But I want to thank you all very much for coming to our webinar today. It's been great having you here. I see that we have a lot more questions in the Q&A that we have not even gotten to. Unfortunately, we're limited on time. If there are any questions that you still have and we have not touched on them in this presentation today or in the Q&A, please send them to us by email. And yes, we will see you in the next webinar. Thank you, Jerry. Thank you, Justin. And come see us at Biomedical.com.
And don't forget to jump into our on-demand advantage training as well. You need to register for that and get a password set, but you can earn additional certificates of completion for each course. And those certificates of completion can be used as objective evidence of your training and your learning for continuing ed